This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi. Sometimes it would be extremely difficult for an experienced surgeon also to delineate the exact location of a posterior capsular tear. Now, I had one such recent experience and I'd like to share it with you all. Now, this is a trainee surgeon who's doing phacoemulsification, and unfortunately the rhexis margin is touched by the second instrument. It is actually a blunt long sense key and it has gone radial. The surgeon has not realized and he's continuing to phaco, and after some time he realizes that something is wrong and the nucleus is not stable and he calls for help. And this is the time I take over. So immediately when I come in, I notice that the rhexis is broken and I want to be very gentle with the maneuvers. At this stage, I still believe the PC was intact. The left side of the nucleus is tilting up. So these subtle signs are very much suggestive that something is wrong. So I'm definitely suspecting a posterior capsular tear at this stage, but as we all know, we can't see the tear because of the overlying nucleus. I just had a glimpse of few wrinkles that was suspicious. I'm going in with some OVD, trying to push it under the nucleus so that I can visualize something. But as soon as I put the OVD, they all disappeared and it looks very homogeneous and I'm not able to visualize any posterior capsular tear. So at this stage, I thought the safest bet here is to emulsify the nucleus in the antechamber. So I put in a lot of dispersive OVD to protect the corneal endothelium, and 2 instruments are taken to maneuver the nucleus out into the antechamber. And because the nucleus is relatively softer, I go and emulsify it in the antechamber itself. And to prevent endothelial trauma, I'm just going to refill the chamber with OVD a couple of more times. So eventually the nucleus is taken care of. As the last piece is taken off, I can see few fibers fluttering, but at this stage I'm not sure it is a PC tear or not. I turn on the stereocoaxial illumination, the retroillumination mode, so that I can visualize better in the red glow. I put in OVD, but I'm not able to visualize any posterior capsular tear at this stage. There's a small patch of cortex. I'm trying to zoom in and visualize. There are few folds in the posterior capsule, again, which is very suspicious. To remove the cortex, I am going in with my bimanual. The moment I go in, the folds are increasing and now it looks like maybe there is a posterior capsular tear. So what do I do now? I can clearly see 2 vertical lines. Now I thought, okay, this definitely looks like a posterior capsular tear. So let me pause the frame here. I can see 2 distinct lines here, and I thought this in-between gap is the area where the PC is missing. That's what was my initial impression. And believe me, this impression keeps changing, so do watch out. So at this point, I would like to test for any prolapse of vitreous, so I'm going to use a diluted triamcinolone acetate. I'm gently irrigating with very low fluid, and I'm surprised that at this stage, there doesn't seem to be any vitreous prolapse and the entire PC is mobile. And again, the area which I thought had a PC tear, that PC is still intact. But now the suspicion is towards the far end. Now this looks to be a posterior capsular tear and I'm just thinking, what do I do now? There's no vitreous prolapse at this stage. Should I attempt to place the lens in the sulcus? The posterior capsule is all wrinkled up. So definitely there is a tear. It is extended from the area where the rhexis is broken. And now I feel that the tear is towards my right hand side. Since there is no vitreous disturbance, I thought let me place the lens first. I'm going to use this OVD to create some space under the iris and above the capsule. So as soon as I'm doing this, I can see a linear fold. It looks like a crumpled posterior capsule at one end. The left hand side has an intact posterior capsule. The right hand, the entire posterior capsule is crumpled to the center. That's what it looks like. So I'm using a Y hook to just retract the iris I'm trying to visualize and see, is there any enough anterocapsular support for me to venture putting lens in the sulcus. I thought there is a reasonable amount of support with the anterocapsule, so I thought let me go ahead. Time to implant the lens. The incision is extended a bit so that the cartridge can be negotiated easily. This is Aurolab multi-piece lens. So I'm trying to land it over the anterocapsule, but unfortunately it is gone and stuck in the area where the anterocapsular tear is. So with the Sync-Yoke, I just lift up the haptic so that it's in a more anterior plane and above the anterocapsule, and then using a Sync-Yoke, the second haptic is dialed in place. So now both the haptics are in sulcus and the haptics are away from the area of the anterocapsular tear. So I thought let me go in with the vitrector itself and do the anti-vitrectomy. I'm assuming that there is prolapsed vitreous there. But as I go in, I realize that there is no vitreous still. Again, I was surprised and taken back, and then the entire posterior capsule unfolds and looks fine. So I thought let me try and remove that little patch of cortex which is there. Well, on the hindsight, I realized this was not such a great idea. Simply because the cortex is sticking very firmly, it is very little, and it is sticking onto a capsule which is not at all stable, and it is wrinkling and folding. As I'm trying to irrigate and position the lens, the irrigating fluid has finally ruptured the anterior hyaloid at this stage. Now, clearly at my opposite end, we can clearly see an enhanced red glow, and obviously we can also see a ring-like thing which is enlarged. So this is the anterior hyaloid rupture which has happened, and when I go in and reintroduce triamcinolone acetate, now we can see that the vitreous is prolapsing from that area. So it took a while for me to successfully prolapse the vitreous out. That's what it looks like. And nevertheless, we need to deal with the vitreous first. See, the important point here is we need to do the anterivitrectomy without sacrificing the posterior capsule or the anterior capsule, so that we still have enough support for the lens to be stable in the posterior chamber in the sulcus. The positioning of the cutter is extremely important. It is positioned below the level of the posterior capsular tear with its bevel down first, and the cutting has begun. So once the vitreous which is behind the posterior capsular tear is taken care of, the bevel is now turned sideways and finally anteriorly to take care of the prolapsed anterior vitreous. So basically we have segmented the vitreous into two parts. The posterior prolapsed vitreous is first cut and the anterior prolapsed vitreous is now separated. Now finally the port is turned anteriorly and it's taken care of. So at this stage we can see the wrinkled posterior capsule unfolding now, and it looks like the tear is more towards the extreme right hand side. The lens continues to remain stable, although it is not in the best centered position, but this is what we are going to get. We don't have an intact rhexis, so that we can't achieve an optic capture. We're placing a large multi-piece lens in the sulcus, so it is still better than most other alternatives. The vitrectomy is continued. I'm just trying to find out other areas. When we're doing anti-vitrectomy, it's important to check near the incisions. You always find one fiber of vitreous, trying to sneak out through these incisions. They've got a great propensity to sneak through the incisions. Always look for them, and eventually all the prolapsed vitreous from all the three ports is taken care of. Diluted pilocarpine is used to bring down the pupil. The irrigation is continuing with my left hand, and once the pupil comes down, again we get an idea where the vitreous is still sneaking out. I can see that a vitreous fibril is prolapsing through the right side port. Again, it's taken care of. So before closing, again ensure that the pupil is round and there's no vitreous fibril sneaking out through any of these incisions. I'm just nudging the lens to just check for its stability. It looks alright. In this particular patient, I'm also doing an iridectomy. It is not mandatory because we've already done vitrectomy, but still in situations where we place the lens in the sulcus and there might be some lens matter which can induce some inflammation. Just to be on the safer side, I'm doing a peripheral iridectomy with my cutter itself. The side ports are hydrated and I want to suture the main incision. Before that, I'd like to put some air bubble in the eye and then suture with a 10 nylon. So without holding the sclera, we can pass the needle through both the corneal and the scleral end and pull it out. Tie the knot. Knots are buried into the sclera. The air bubble is removed, intracameral antibiotics are placed. That's it, the case is done. And these are the post-op pictures. Initial, for the first week, the cornea was edematous and gradually it's improved. The lens continues to be stable and well centered. Okay, to summarize, in this case, it was really challenging for me to delineate the posterior capsule tear. That is, to understand the morphology, where it is starting, where it is ending, and the entire posterior capsule was fluttering around, but was folded. In spite of having seen hundreds of PC tears, this was one case which was challenging where I wasn't able to really delineate the PC tear to begin with. Nevertheless, if you're focused and search for it, eventually you'll find the delineation of the posterior capsule tear and manage it appropriately. So that was it. Thank you for watching. I hope you found this helpful.